It gives me immense pleasure to introduce Dr. Bharat Bhosle, a renowned consultant medical oncologist associated with Bombay Hospital and BB Precision Oncocare Center. Dr. Bharat has extensive experience of 17 years managing a wide spectrum of cancers. Today, Dr. Bharat will be sharing valuable perspective on breaking barriers in MHS-PC doublets, where darolutamide plus ADT leads the way with AREL. Please join me in welcoming Dr. Bharat Bhosle. So over to you.
Yeah, so I need to share it again. My screen is visible?
Yes, sir, your desktop is visible.
One second. Now?
Yes, sir, yes, it is visible.
Yeah. So, yeah. So thank you, Bea, for giving this opportunity. Since last decade and a half, there has been a significant evolution in terms of management of both hormone sensitive as well as hormone resistant prostate cancer. Field is becoming more of a precision medicine is taking slowly in solid tumors after hematological malignancies. There was a time when there was only one drug, mitoxantrone, then docetaxel. Apart from the ADTs, we hardly used to have options. So before going to the topic, so context is we have now four or more than four coming of androgen receptor peptide inhibitors, and we will be discussing the third generation drug, and this is the spectrum of standard of care, how it has evolved from 2000 and after that. So most of the innovations came after 2000, and the only treatment available for prostate cancer was orchidectomy, or there used to be comparison of continuous ADT or intermittent ADTs, keeping in mind the quality of life. And then came the chartered and standard for the first time. They tried to look at the chemotherapy ADT with steroids. Subsequently, there were different arms in the Stampede, Abiraterone, zoledronic and hormone sensitive. And we all know in last decade, we have moved from latitude, Stampede, other arm. Then came the Titan, Arches, Enzamet, that is enzalutamide. And recently, darolutamide is the third generation drug which has been added to the armamentarium along with the ADT chemotherapy or only with ADT. So we'll briefly discuss. So in spite of the last decade's advancement, we still have a scope or there is an unmet need of an effective molecule. Especially in the hormone sensitive, where we don't want the patient to fail in terms of the PSA rise, in terms of the pain, in terms of the skeletal event, and ultimately radiological progression-free survival, and ultimately the progression-free survival. So today's interest is darolutamide. So we'll keep it limited to the discussion of darolutamide. So as I discussed, the unmet medical need remains for an effective molecule, for effective treatment that offers a differentiated and a better safety profile for patients with metastatic hormone sensitive prostate cancer without adding too much of toxicities with a least drug-drug interaction. Because if you see these old patients, mostly they are on multi or polypharmacies, and there are significant interactions, prolongation of QTCs, liver dysfunctions. So we need to have ideally in this subset of patients, which is geriatric population of prostate cancer, a drug which has least interaction with over-the-counter available drugs. So the phase 3 trial ARASENS has already showed a beneficial effect and a safety profile in this subset of patients who are hormone sensitive, leading to approval in India in 2023. Then darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in the same subgroup. And that has been shown in the study ARANOTE trial, which has significant Asian patients, especially Indian patients. With this data, darolutamide has a potential to change the treatment paradigm, as now it would be the only androgen receptor inhibitor which could be used with or without chemotherapy. So Daro plus ADT with docetaxel is the standard of care for metastatic hormone-sensitive prostate cancer. So triplet, what we called as ADT plus Daro plus docetaxel. In ARA sense, Daro plus ADT plus docetaxel demonstrated a favorable efficacy and safety as compared to two drugs, that is ADT and docetaxel, which we have used a lot in this sensitive population. But still, we feel that no, there is a space for improvement, and adding this Daro with docetaxel ADT is superior to the doublet. And this particular trial, Aranut, was designed to evaluate whether doublet, that is ADT with only darolutamide, is better as compared to ADT. Nowadays, nobody uses ADT unless the patient is fragile and where the drugs are contraindicated. So this is the trial design. It's a randomized, double-blind, placebo-controlled phase 3 trial. The initial part was double-blind phase until the primary analysis. After the primary analysis, it made unblinded. The trial was kept open-label phase until final analysis. So metastatic hormone-sensitive prostate cancers, roughly 670 patients, proven malignancy, good performance status, and the stratification was visceral versus no visceral mets, and prior local therapy was given or not given. So, de novo or whether the patient has relapsed after the local therapy. Randomization was 2:1. The experimental drug Daro 600 BD with ADT versus placebo plus ADT. And the endpoints were radiological PFS, and there were key secondary endpoints like OS, time to CRPC, time to PSA failure, rate of undetected PSA less than 0.2 nanogram per ml, time to pain progression, safety, and other pre-specified endpoints like PFS2, time to subsequent SSCs, time to deterioration of the FACT-P protocol, so looking at the quality of life, and time to first prostate cancer-related invasive procedures. So in the second half, after the interim primary analysis, open label Daro and 100% crossover to open label Daro. And subsequently selected endpoints were OS and safety. So if you look at the patient demographics and clinical characteristics, well balanced, and you see there are 33% of the Asians represented in the experimental arm and the standard arm as well. Looking at, they all were good performance status in both the arm, well balanced. And if you see, the de novo metastasis at initial diagnosis was majority of the population, that is around 70 to 75%. And those patients who presented after initial treatment are roughly around 20%. Disease volume, which we described in charted high versus low volume, the majority of these patients were high volume disease. So if you look at the previous trials of prostate cancer, the AA302 trial, the Aronet trial, Vision, and the other trials, this trial has a significant representation from APAC region, that is Asia and Australia, this China, Taiwan, New Zealand, India. India has nearly fairly 15% of the patients represented. So this trial is actually, if you look at the other trials, is a really global trial where we are represented as Asians. So if you look at the numbers, it's North America 39%, Europe 38%, and the rest of the world is 23%. So Daro plus ADT significantly reduced the risk of radiological progression, which was the primary endpoint of this trial, and reduced the death by 46% as compared to ADT alone. So if you look at the 2 years figure, it is 52% with the ADT only, and 70%. That's a survival, progression-free survival at 12 months, 24 months is 70%. Hazard ratio of nearly 50%, like 46%. So median follow-up of this trial was 25 months for darolutamide and 25 months for placebo. The benefit of Daro on relapse, on the radiological progression-free survival was consistent across all the subgroups, including patients with high and low volume disease. If you look at the chart, and it is clearly visible whether it's a high volume disease or low volume disease. This can be the treatment option. At the time of primary analysis, the overall survival data was immature. Since OS is immature, patient will be followed up for survival. All remaining per protocol placebo patients offered crossover to Daro after primary analysis. Coming to the time to CRPC, that is progression to the castrate-resistant prostate cancer from the sensitive, and time to pain progression. Both the parameters, there was significant improvement. If you look at the hazard ratio, it is 60% reduction in the risk of progression to metastatic CRPC, and there is a 30% reduction in the risk of pain progression with the use of adding Daro to ADT. So there is a definitely delays in time to pain progression and can be of highly importance for such patients who are in pain because of this colorectal metastasis. Daro plus ADT achieved a deeper and a durable PSA response. If you look at the deeper response, which is less than 0.2, how fast it is achieved and how long it is maintained is very, very important. And Daro adding to the ADT, if you look at the percentage, it is 62% versus 18.5%. So 63% of the patients in Daro doublet attained PSA deeper response. This represented as a 70% improvement in time to PSA progression in Daro. That is, the response is maintained for quite longer time. When you look at a higher proportion of patients achieved undetectable, that is a deeper PSA response with Daro versus placebo in both high volume as well as low volume disease. If you look at the right hand side and left side, both the places, if you see darolutamide has achieved a maximum percentage of patients achieving the deeper response in both, irrespective of how high or low burden of its disease was there. Then coming to subsequent life prolonging anti-cancer therapy used in both the arms. As I mentioned, in the placebo, majority of the patients or all of the patients are offered darolutamide, and they actually had access to darolutamide. Patients who discontinued therapy in both the arms, if you look, it is 45 versus 71. Patients with subsequent life prolonging systemic therapy, 32 versus 42%. Docetaxel nearly 23 and 28% of the patients. And if you look at the other therapies, more or less it is same. Incidence of treatment emergent adverse effects were similar between the treatment groups, and discontinuations were lower in Daro arm. And that is how it is a safe drug. Median treatment duration was 24 months in Daro and 17 months in placebo arm. The safety profile of Daro was independent of PSA response and consistent with favorable tolerability first seen in the previous two trials. So rates of most common adverse events were low and similar between the two arms. What is seen is anemia. It's more or less same. Grade 3-4 anemias, arthralgias, UTIs, back pain, increased liver dysfunction, increased AST, constipation. Grade 1-2, no. Grade 3-4, hot flashes, nearly similar in both arms. Increase OTPT, similar in both arms. Pain in extremities, similar in both arms. So more, and if you look at the systemic symptoms, side effects like hypertension, this is grade 3-4 is 4% and 3.6%. Increased weight, again, it's not significantly different between the two arms. And insomnia, but that is also not in 2 digits. Fatigue was a bit reported in 6% of the patients versus 8% of the patients, so that is also not the concern. So these are all actually a manageable side effects. So this is again the rates of adverse event commonly associated with androgen receptor inhibitors were similar across the treatment arms. So darolutamide confers a positive impact on health-related quality of lives. Daro extended median time to deterioration in FACT-P total score by 5.1 months versus placebo. So darolutamide is the first and only ER inhibitor to demonstrate clinically meaningful delay in pain progression and overall well-being. So in terms of quality of life, addition of Daro to ADT is definitely gives a better quality of life. When we look at the primary endpoints like achieving the deeper response, maintaining the response for a longer duration with a good quality of life is very, very important. Daro doublet therapy demonstrates clinically meaningful delays in deterioration of overall well-being, especially in social, functional, and urinary symptoms domain, which is very, very important for geriatric patients with a prostate cancer who has extensive bony metastasis. So again, to remind you, it has showed benefit in high volume as well as low volume disease. So in terms of deterioration to FACT-P subscales, these are the findings, and definitely we see a positive impact of Daro on addition to prednisolone and addition to ADTs. Daro ADT significantly improved radiological PFS, that is progression-free survival, in patients with metastatic hormone-sensitive prostate cancer. Daro showed a benefit across all secondary endpoints. Daro was associated with a deep PSA response regardless of baseline PSA. Darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including social family well-being, functional well-being, urinary symptoms, and darolutamide had a favorable safety profile. Darolutamide plus ADT without docetaxel should become an additional standard of care for metastatic hormone-sensitive prostate cancer. Thank you, and I would like to have take questions from the audience if there are any. Over to you, Kritika.
Yes, sir. Sir, we have one question. The question says, what makes darolutamide your preferred choice over enzalutamide or apalutamide in certain cases?
So if cost is not the constraint, looking at the safety profile, if you see, I have showed no data speaks for itself. We have our own challenges for abiraterone and enzalutamide, though we should not talk about the cost. I think this molecule should be considered over other molecules because interactions with the other drugs, because as I mentioned, these old patients are always on the polypharmacy.
Yes.
Abiraterone has its own challenges. Having said that, the lower dose reduces side effects to some extent. But again, the drug interaction remains. The QT prolongation is the problem. Pedal edema is the problem. LFT derangement is the problem. Enzalutamide, obviously, apart from the seizure profile patients, we avoid it. But still, fatigue is a big problem for enzalutamide. And keeping my heart on the hand on the heart, I can say that most of these patients are elderly. They keep on complaining fatigue and it. So giving full dose, somebody who is giving a full dose, hats off to him. But I have to reduce the dose. And we know that if you are not achieving that deeper PSA response is difficult. So it's a new drug. Obviously, cost is a constraint. You have to work on that. And a couple of patients which I have used, definitely it's better. What it does is delays the progression to the castrate resistant phase. And if you can do that, you can effectively use the other drugs or re-challenging chemo and other things can be done. Now there is no need to use docetaxel with this drug. So you are keeping that option in the future as well. Because after the abiraterone docetaxel trial, like people are using more docetaxel, abiraterone together. But with this drug, the data looks very promising. I think you should not jump to addition of docetaxel. That is also a good point for this drug.
Right, sir. Thank you so much, sir.
Thank you. Thank you.
Anybody has any question? Yes. I check the chat again. So, sir, no questions. So, on behalf of Bayer, sir, would like to thank you for presenting such a valuable perspective of darolutamide from your end.
Thank you.
Thank you so much, sir,
for
your
time. Thank you all. Thank you.
Good night, sir. Good night.
Good night. Good night all.